Welcome, everybody. I'm Dr. Stephen Rasner, and this is the Lionhearted Dental Podcast. Tonight, out of all the podcasts that I've done since 2018, I think this one could be the most informative game changer for those of you that are already doing dental implants or are in a maxi course or a didactic program somewhere, and you're getting ready to take that giant leap that's so exciting to begin actually placing your first implants in your own dental practice. So tonight's podcast was born from me thinking, you need to hear this. And what it is you need to know that I've done implants for now, I believe, 30 years. For at least 20 of those 30 years, I did freehand implant placement. That's what I was taught at the Misch Institute in the 90s. That's all I knew. And you can laugh at me for this, and you should. I remember when I heard the concept from all my friends of guided surgery, I remember thinking, that's for sissies. That's for guys that don't know how to do surgery. I don't need that. I remember literally thinking that absurd concept. Let me just tell you this. I did 2 implants yesterday, both guided. In fact, even if I want to go freehand, I still go through the protocol of guided. I think it's actually irresponsible for you not to do that. I do. And you're gonna know exactly why before this day is out today. But let me take you back to another reason. And this is a lion-hearted Steve Rasner type of protocol. It's this. What you and I got into, the field of dental medicine, is very, very challenging. It is so challenging. Especially if you're a general practitioner, because there's so many things that you have to be good at. And there's so many elements of a given day that are unpredictable. Give you an example. Yesterday in my office, a patient in hygiene who's wearing a bar overdenture prostheses. So in her mouth is a bar on implants that I did years ago that comes in and out. It's removable. And a lot of these patients need attachments changed when they come in for recall. Well, I thought it was a quick thing we could do in 5 and 10 minutes. And when she got in the chair, she has screwed in ball attachments on this bar, and one of them came off. So to get that back on, I wanted to take the bar off, and it had been in her mouth for years. Well, 3 of the 4 implant screws screwing the bar in came out in 2 seconds. The 4th one became what's called cold welded, and I couldn't get it out. And it turned into a 45-minute anxiety-provoking clinical situation that I caused, by the way. I'm smart enough and have been in this long enough to know I should have rescheduled this to begin with, but I didn't. That's what I mean by dentistry being unpredictable. When you incorporate guided surgery as part of your protocol, everything becomes simplistic, predictable, stressless. And the more of that you have in your career, the longer your career is going to be, and the happier you're going to be. So that is my primary reason. Tonight, you are fortunate to have one of the lead doctors from a company I use called 3DDX. 3D, what's it called? Tell me, he can edit it. Yeah. A company called 3D Diagnostics. Now listen, you can use whoever you want. There's a multitude of companies that provide this service. But I'm very peculiar. I am very particular who I use in my arena of people that help me deliver oral health care. And one of the reasons I'm so fond of 3D diagnostics is because, as you're about to see, they're incredibly prepared, incredibly professional, accountable, responsible, and incredibly pleasant to deal with. I need every one of those attributes when I pick a company. So without further ado, we're fortunate tonight to have Dr. Etri, one of their planners. They have many planners. I've used several of them over the years. I've been fortunate to work with her. She's incredibly knowledgeable. And welcome to the program, Doctor.
Hello, Doctor. Thank you so much for this beautiful introduction. Really, it's my pleasure talking to you every week or every other week throughout the year. It's always a pleasure to have doctors who are actually keen on the patient's care, the patient's health. You are not just one of these doctors that want to go in, throw the implant, and take the money. You're actually very,
No.
very considerate and very particulate, as you mentioned, in your cases. You put in the effort, you put in the work, and this is what we're here for. Thank you so much for
Yeah.
having me today. It's such a pleasure.
Oh, it's my pleasure. And you see how she's talking right now? That's not just for you. That is how she always is. In fact, that's how they all are. It's like I wish I could get my team to study how they greet their customers or clients because it's incredibly positive karma. I mean this. It's really, really amazing. And, it's just, listen, those two implants I did this yesterday literally took me less. They were single implants. I get it. But they took me less than 25 minutes from beginning to end. And that just not would have been the case otherwise. So I find you incredibly a great communicator in the knowledge that we're going to be speaking tonight. So why don't you begin telling my audience why guided, in your opinion? Why do you go guided?
We go guided for so many reasons, and to properly answer that, I need to specify the clientele. So we have two types of clientele: newly beginners, general practitioners, people who are just starting their journey, and very experienced professionals like yourself. They've been doing it for years. But the number one common cause between both of them is it saves time. And let's agree on something: time is money. And we all work, of course, to achieve success, but also to make good money so that we can retire one day and have a good time when we're like 60 or so. So the surgery that would take you like 30 minutes, let's say it's going to take you 10 to 15 if it's complex. A full arch surgery, a full arch stackable guides, the entire hassle can take you 40 minutes under, like, give or take, depends on the complexity. So it saves you a lot of time. The second reason is, as you mentioned, higher accuracy and predictability. The difference between you checking the CT and saying, yes, this is good enough for bone, I just reviewed it, everything's going well, and what we do is that we tell you all the in and outs, things you might have not noticed, things you might have not had the time to actually think around how you're going to work with them. So you go in, if you need to graft, where you need to graft, your implant to crown ratio, your soft tissue thickness, because this matters significantly, the amount of bone profiling if needed, the amount of bone reduction is needed, the angulation, the inclination, how you're going to restore, any challenges that are going to face you from point A to delivery, like from the moment you evaluate the patient until you put on that final prosthesis. We evaluate the occlusion, all the in and outs. So this is why it's more predictable, and it's it's pretty much accurate in most of the cases. The margin of error is like 0.01%. This
And I
is
want to say one more thing right now. Some of you are thinking right now, I know it. I've been doing this a long time, and some of you are clinicians are incredibly cost driven. Everything you do, and you're sitting there thinking, yeah, but then I have to add the fee for it. Let me tell you something. That's an important lesson. I hope you take away from this tonight. When I do a 3D, when I started doing 3D reads, like I do everything, or incorporating 3D diagnostics, I don't make any money. I don't need to make any money off what they charge me. That's me. But I do incorporate enough of a fee as part of my implant. So when I do an implant, there's a fee for the implant, the restoration. Am I doing a blood draw for PRF? Stella Life, which is another company that I use. I use this all with everybody. And now I always use them. So here's the thing. If the added cost is a few $100s, whatever it is, and by the way, I add enough that if I want to add a custom abutment, I'd never go back to the patient and say, oh, I'm going to do a custom abutment and change the fee. Never do that. Pick out a fee that you go speak to them first, that you think will cover your read, the production of your guide, if you're going to use a custom abutment, or if you're going to, not abutment, I meant a custom healing cap, and or you're going to use a tooth, an immediate tooth. And you're not going to do that on every case.
True.
If your patient denies and declines the restoration because you added $400, then you're doing something else wrong in your approach to case presentation. I am telling you, I have never had one patient, not one, ever say to me, oh, that's too much money, or can you skip that part of it? It's just something in your head, and I'm trying to make your life easier. This is going to be part of your fee, and it's not going to be the reason they turn you down. Thank you. Continue.
Of course. And doctor, I want to add to that, it might be a reason why a patient trusts you. They know they're not just another case. They know you took the time and took it upon yourself to optimize the case. So again, back at accuracy and predictability. We're not going to give the patient something they're not going to want. And
what do my guys need to start? When they're out there, they don't know. Go ahead.
Yeah, what they need is, like, we need a bunch of documents and a bunch of, let's say, tools. Okay. When it comes to the documents, we require a full arch CBCT that covers the entire arch of interest and around 5 millimeters of the opposing arch with sufficient teeth separation. And we also need an intraoral scan or an impression if you don't have an intraoral scanner, as long as if it's good quality, and we scan that model. These are the two minimal things we start with. If you want to add a bit more accuracy, occlusion evaluation, we need a bite for that. Okay, so you'll send us upper intraoral scan or impression, lower intraoral scan or impression, and a bite. Okay, this way we can evaluate everything. And how we do that is that we create a virtual patient. We take the patient that came to your clinic and we put it on the software. We take points over the CBC and we take the same exact anatomical landmarks over the intraoral scan or impression. We stitch them together so they fit like a puzzle. Okay, and this way you have a virtual recreation of your patient. So we use the CBCT to evaluate the bone available, any bone defects, the space between the roots, what we can do with the implant, and we use the intraoral scan to plan the crown. And to me, you know that we've done this a million times. I always say, let me take a moment to tweak that crown, because we follow what we call a crown down approach. Why? Because a successful implant is a restorable implant, and an implant that would have good prognosis and longevity. Okay, so if something is up with the bite, with the crown, something is not accurate there, whatever we put in the bone might not withstand the forces. It might not be ideal, and the implant might end up failing due to occlusal reasons. If we plan it blinded regardless of the crown, it might end up with an emergence that's really not properly restorable, giving the patient a bulky crown with like a cantilever effect, whether it's buccal, lingual, mesial, distal, causing a lot of complications later on, whether they're in the soft tissue like gingival inflammation, causing the patient some pocketing, and eventually leading to the number one leading root cause of failure of implants, which is periimplantitis. Okay, and this is exactly what we try to prevent. The second thing that they need is a set of tools. And when we say tools, we mean what are you going to use? So here's the thing. With freehand surgery, you open up the patient, you take your drill handpiece, and you start drilling. With guided, we want that handpiece to go in specific angulation, inclination, and depth. This is the entire point. And this is why you need one out of two things. Either an entire guided kit that provides you with guided drilling and sometimes guided placement, depends if it's fully guided or partially guided, or just one pilot drill that would fit through the sleeve. The difference is one would allow you to drill through the entire sequence, okay, and sometimes place the implant. The other one would just mark your initial osteotomy, and this saves a lot of hassle during the surgery. Am I right?
Yeah. I want to say two things. And Dr. Atri might get to this later. But for years, I told you guys, for 20 years, I did freehand. So what would that look like? Well, think about it for a minute. Think about this in your busy dental practice. Because you're not going to probably, if you're a GP, you're probably not doing dental implants all day long. So you have other things to do. So when you go in to do the implant, if you're doing a freehand, there's a moment, so you have to flap, of course. Not of course, but a lot of people, I do. I flap most of my cases. But there's a moment where you start the osteotomy. And if you don't have a guide, how do you know if I'm the implant? Does it make a difference if I'm a little mesial, distal, if I'm not centered, if I'm a little buccal, lingual? All those things, like understand, lead to cantilevers. A cantilever is a primary reason for failure down the road. And I'm going to tell you something, and it's humbling for me to say this to you. I can't tell you how many implants I look back on, particularly in the anterior maxilla and mandible, that are absolutely cantilevered to the buccal. And it wasn't that I was not trying. I looked. I got up from the patient, and I looked to the left, and I looked in front of them. And I had my dental assistant stand in front of me as facing me, and she would say, that's how we used to do it. Doctor, doctor, assistant, assistant, with the drill, so we wouldn't be mesial or distal. What could be easier than placing a guide and just going through the osteotomy ring that doctor will eventually talk about? It just reduces stress and increases accuracy. If you haven't entered this arena of guided, I can't overemphasize. 3D Diagnostics is not paying me to do this. I am doing this because I want you to know that this is the way for you to incorporate dental implants into your practice, number one. And number two, take the stress out of it. You know what else happens? You'll go in to a case two ways. You'll think, I'm positively going to do an extraction and an implant at the next visit. So that's factored in to your productivity that day and all this stuff. When you do the planning session that you have to do, you may very find out that day, this is not a good case to do single stage, that you want to place, remove, graft, and come back in 16 weeks. I don't care about all the theories that it's better to do it the same day. Sometimes you simply cannot do that. And this is the time. That's a lot better than having a failure 12 weeks later, because you didn't have enough stability of your implant. So it's another opportunity, including to tell you exactly what you are going to do that first visit. Obviously, I'm talking about immediates when you extract. So I just wanted to say that, Doc.
Of course.
How about talking about, if you want to, at this stage, what are some of the common issues about number first that are problems for CBCTs that they'll be sending, and then secondly, intraoral scans?
Of course. So with the CBCT, the thing is, in a lot of cases, we receive a CBCT that we call suboptimal. Why are we calling it suboptimal? We're calling it suboptimal because it's not giving us proper visualization of bone. Number one most common thing is mirroring slash haziness. Mirroring happens when the patient moves. Patients, in a lot of time, they end up making this slight movement as they're being scanned. What this causes is the repetition of the same image. So when I'm planning, I often tell you that I don't know exactly where the buccal bone is. I don't know exactly where the lingual bone is. I don't know where exactly I am, which contradicts the idea of accuracy. This is a reason why we'd ask you for another CBCT scan. In a lot of cases, the mirroring is very minimal. It's just in one area. It's just this few slices, so it's okay. But when it's significant, it can significantly affect the implant position in bone. The second thing is haziness, and this often occurs due to lack of CBCT calibration. A lot of doctors, they're having a busy life, busy days. They like the team just sort of slips the idea of recalibrating the CBCT machine. And when that happens, I can't see where I'm measuring from. I can't see the fine details of bone. I can't see if we have a nutrient canal in there. I can't see if we are accurately tracing the nerve. So this matters. The second thing we face a lot of times is artifacts. And let's just put it that way. We can't remove the metal out of the patient's mouth. So what we can do, we can adjust our CBCT machine. Most of the machines nowadays, they have these special calibration settings, okay, that you need to adjust when you know that the patient has a lot of crown work, maybe has an implant in there. This helps reduces the artifacts. Why do we want to do that? Because imagine this. You have a lot of rays, a lot of beams everywhere covering up the bone. Regardless of what I can do, regardless of the planning with a margin for error, okay, trying to accommodate it, I know very well that I can't see the bone, which again contradicts the idea of accuracy. If there are minimal artifacts, or if we believe that this is the best you can do, so we're going to have to deal with it, we tell you we can proceed with your approval unless you want to give it another shot. But in a lot of cases, we tell you we cannot proceed with that. The problem when the issue is in the CBCT, it affects the implant position. And once the implant is in there, it's in there. You've drilled the bone, you've placed the implant, there's nothing really much you can do about it. So this is very
So
significant.
to be clear, yeah, I don't want you guys to think this is hit or miss. Like you send them in, and 62% of the time they're hazy or there's movement. 3DDX has written protocols of what to do to get optimal CBCTs, including separating soft tissue, what they bite on. And I had to learn a lot of these because I had way more repeats in the beginning than I do today. So it's not random. They'll guide you, and their protocols are very reliable. Good.
Yes, and we always assist, like we're always here if a doctor is facing any issue with a scan. We always can help, and even if it's something unconventional, like a once in 100 patient kind of situation, okay, we go around, we research, and we get back to you with the answer. If we can't have like if this is the best we can do, we have also a protocol to follow, okay, if you're going to work with that margin error, and we say proceed with caution. But what do we mean when we say proceed with caution? We mean you've drilled your initial osteotomy, the pilot drill, Okay, the number one. So you're going to take that paralleling pin, put it in that initial osteotomy, take a PA of the patient, and check, open up the plan right next to you and check. Does this look mesiodistally accurate? Like, is this okay? Does this match the plan? And then you're going to have to look intraorally at the patient from multiple angles and check the buccolingual angulation. And in that case, if you felt that you're totally off, you have the total freedom, if you can, to adjust that free hand during the surgery or graft the initial pilot osteotomy so we didn't do that much damage, okay, aboard, and then recall the patient in a while. But we always let you know that something might happen. And for the last thing that we like cross when it comes to CBCT issues is that some doctors give us a short span CBCT, like 4 to 5 teeth. This is not enough because remember when we talked about the virtual patient, we take the entire arch, we take anatomical landmarks, and we stitch them over like to the intraoral scan. If I have a short span part and a full arch intraoral scan, I know that my registration might not be accurate. I know that it cannot evaluate the entire arch. I know there might be something that I'm not able to visualize that might be significant. I can't evaluate the long axis of the tooth in contrast with the arch. I can't evaluate a lot of things. Okay, so this is why we have very specific protocols when it comes to CTs.
How about the actual intraoral scan? What issues do you see there? Or impressions? Either one.
Yeah. Well, the first thing that we have is, as we said, a short CT is not enough. A short intraoral scan as well is not enough. And why is that? That's a different reason. How do we fabricate the guide? We fabricate it virtually over the software, the same way you'd fabricate a stent or a night guard over a model. If I have a model that has the span of 4 to 5 teeth, your guide extension would be 4 to 5 teeth. If that's okay for you, if you feel that this is convenient for you clinically, we can proceed with it. We don't recommend it, but we can proceed with it. But our protocol says 9 teeth in front of the implant site for maximum support so that once you tripod the guide, it's easily tripoded and supported in place. You don't have to like keep checking and you're working in such a tight spot. Like it's already tight. We don't need to make it even more squeezed in. And the second thing is to maximize the support of the guide over the teeth. You don't have to suffer from like torquing or rocking upon like drilling, because at the end of the day, we're drilling with speed and force. So this needs proper stability. This is the first issue, which is a short span intraoral scan. The second thing is a defect on the intraoral scan. When we have such defects, there is a way to work around and still fabricate the guide. But the fitting surface of the guide, it's highly possible that it's going to be inaccurate at the time of surgery to match the patient's actual anatomy. So you're going to have to take it upon yourself to tweak or adjust that if it's causing the guide to be ill fitting. And we never recommend to do any adjustments to the fitting surface because if you're not very experienced with the material of the guide, you might end up fracturing the guide or perforating the guide, causing distortion. So there are a lot of things that can happen wrong. So when we have missing information like short span intraoral scan or defects on the intraoral scan, like missing areas, we always recommend to have another one. The second thing,
Oh,
sorry, go ahead. Yeah.
go.
Okay, the
Go.
second thing is when we have a model of the patient, a stone model. Stone models can have a lot of defects, like air bubbles, broken teeth, an area that is totally like distorted, okay, an area where the impression material didn't really record that well. Okay, all of these cases will be reflected on the fitting surface of your guide. So if you have an air bubble, we're going to try to treat it as the best as we can, but it's going to be reflected. If we have a chipped out tooth, we're going to try to treat it as best as we can, but still it might be reflected. When we know we might have an error on our end, the number one priority is to inform the doctor and let them know what might they face. Like you might face a little torque, you might face that it's not being fully seated. This might happen, that might happen. So these are the most common effects that happen with intraoral scans or models.
So at some point, doctor's going to talk about the different types of guides, and you're going to hear me encourage you as I am at a course I'm going to do in a month. Like in the beginning of your journey, you need to get your confidence up. So you should obviously go for implants are not all the same. So doing a full arch that requires a bone supported guide after you flap is quite a bit different than you doing a tooth supported guide. So I want you to know, and Dr. Etchery is going to get to it later, but when you do everything right, I'm telling you, the things that she's alluding to right now really do not happen very often. I'm not going to say ever, but they're not common. When you do a tooth supported guide, if you snap it on the teeth, you've done all the parameters they recommend, and there's little windows that are very easy for you to look at to see if you're fully seated. The windows are on the teeth that you're putting the guide on. So there's no guesswork. You can see, wow, first of all, it'll fit. It'll feel like it's down. And if I had to give you a percentage, it's 9.5 out of 10. It's not 9 out of 10 or 8 out of 10. It's almost all of them. And then it feels good. Then you look, oh, I'm down all right. And you're down. So now you know, okay, I can proceed. I want you to remember me telling you this, because that's going to be a really good day in your office when you go to seat that tooth-supported guide and you follow these protocols. So, in the beginning, just don't take shortcuts. Call them up and say, what do I need to do with this? And just do it. Do it the right way, because one failure out of 50 is too many. And it happens to the best of us. It does. I'm telling you something. One failure, then breaking into the patient and having to deal with that uncomfortable scenario, when it's avoidable because you've given the right information to begin with, that's the way you want to go. So that brings me, doctor, to, because you're going to have a session with somebody like Dr. Etchery, like we're doing right now. Mm-hmm. And you're going to be on the computer with her. And at some point, she's going to say, or somebody else is, how do you feel about that? You've been in this case for 15 minutes discussing. How do you know? What is your metrics or your guidelines if we have a good, reliable, safe plan?
Okay, so we have a lot of things to consider when it comes to the planning process. The first thing is safety, and we prioritize safety overall. So we have a lot of things to be safe of. If we're talking about the mandible, okay, number one, we have the nerve, the inferior alveolar nerve. Okay, it's the big elephant in the room in there. So what we need is 2 millimeters away from that inferior alveolar nerve. In a lot of cases, I tell you something like, we don't have enough to plant the implant above that nerve. So we're going to have to either try to build up the ridge, or try to look for an alternative process, okay, an alternative scenario. But as long as we can maintain 2 millimeters away from that nerve, then we should be safe. And at the area of the foramen, very specifically, in a lot of cases we'd be doing, and I tell you something like, I overtrace the foramen a little bit just for safety. And why do I do that? Because it's such a sensitive area. We don't want to have any flaws or faults at this point. Okay, it's very sensitive. The second thing in the mandible would be the lingual concavity. We always want to try and maintain around 1.5 millimeters away from that lingual concavity to avoid any mishaps, to avoid fracture, to avoid any possible resorption that might happen apically at this point, okay, due to forces, and cause a communication part at this area. Okay, in some cases we tell you it's less than 1.5, but it's okay because we're on the inside of the lingual cortical plate, which means during any point of your surgery, if you touch dense bone, you know you've went too far. Okay, so regardless of you're doing something that is fully guided or if you're going like freehand, you know that you are not engaging that lingual plate, you are on top of it, so we're safe. Okay, but we try to maintain that safety measurement as much as possible. In the maxilla, we have a lot of things to consider. The sinus, we can engage it, but are we too aggressive? Would it possibly perforate? If one of the threads is too aggressive, do we have a thick sinus lining, or is it too thin and this aggressive engagement might end up causing like a rupture in that membrane? Is it safe or not? If we're bumping, how are we bumping? Okay, are we leaving like half a millimeter of bone for like specific protocols, or are we going all the way to the cortical lining? The nasopalatine is very sensitive. Are we engaging? Are we aggressively engaging? Are we possibly slightly perforating? And by the way, I've been told with a lot of doctors, like we do the plan and I tell them we're aggressively engaging and possibly slightly perforating. Okay, and they proceed with the plan hoping everything goes okay, and then they get back to us, the patient is feeling like this discomfort in the anterior zone, and this is when we know that yes, we are aggressively engaging and possibly slightly perforating. It's a cortical plate. Okay, it's not that dense. We have something called canalis sinosus. It's a canal that carries blood vessels and, in a lot of recorded cases, innervations. Okay, so are we going to engage it? Are we not? Are you going to take the risk or not? The nasal floor, a lot of considerations. Okay, so we need to plan accordingly because at the end of the day, we don't want to end up causing damage that would complicate the surgery and the follow up for you as like the surgeon that did the surgery. Okay, so this is when it comes to safety. When it comes to planning, we have parameters that we follow. So we're talking like pure academics. The implant to crown ratio should be around or more than 1 to 1. Why? To avoid vertical cantilever. And since we're at this point, I just want to like do a quick review about the types of cantilever that can happen over the crown. So this is a crown, it's a 3D item, okay? You can have any mesiodistal cantilever if you're not centered. If you're more towards the distal, you're going to have mesial cantilever and vice versa. Okay, you can have buccolingual cantilever, okay, and this can happen upon occlusion. So you can end up, if the implant is a little too lingual, you'll tip off the buccal, causing eccentric forces and a lot of tension. Okay, and you can also have, which is a lot of people miss, you can also have vertical cantilever. So think about it. Does it make sense to hang like a 15 millimeters crown over an 8 millimeter restoration with all of the lateral forces that are going to happen? It's going to end up moving in that direction because it's not properly anchored, and it will cause tension. And what we need to remember while planning is bone grows under compression. It starts like deteriorating under tension and shear. Tension and shear happen due to eccentric forces. Our natural teeth, they have PDL ligaments around them that act like shock absorbers. They take in those eccentric forces and they try to accommodate it. This is why with our teeth, we don't have to think about it. But then you'd have a case that's presented with mobility due to malocclusion, not because the patient needs endo restoration or anything, not because of a fracture, because of the bite. What did the bite cause? Tension and shear excessively over the bone, leading to widening in the PDL space and ending up in mobility in the tooth. So, implant to crown ratio, we need to keep it around 1 to 1. Studies have said that the forces distribute over the first 10 millimeters of the implant being in the most minimal at the most apical, like 1 to 2 millimeters of these 10 millimeters. So why should I go for a 12 millimeter implant, an 11.5, a 13? For anchorage. That's the reason. That's the main reason why. And when it comes to implant diameter, we check the crown, okay, and academically we say 2/1. So if your crown, like a smaller crown that's around 10, 11, 5 millimeters in width, we want to go for like a 5 millimeters. Maybe 4.5 would be acceptable, but definitely not a 3.7, not a 3.5. This is too small because think about it. There goes your implant, and there goes your entire crown. So this part of the crown is centered. How about the most distal and mesial couple of millimeters? They're going to act as cantilever. So this is why we try basic. Okay, so implant to crown ratio 1 to 1 when it comes to length, 2/1 when it comes to diameter. And
Every time you do a planning session with Amy or one of them, it's like taking a 9 month course in didactic implantology. How does she know all these things? I know we all were taught them, but they just come out. They just, it's unbelievable every time. It's I don't know how you know all this. I know it, but I can never just espouse it the way you do. Congratulations. It's very good.
thank you.
Go ahead.
Thank you. But this is another thing. Here we're not just dentists. You're not just talking to dentists. You're talking to people who are trained to pay attention to all of these fine details. Okay. I don't know if I was in there doing 9 to 5 surgery all day long, 8 hours, 6 days or 5 days per week, if I'd actually have the time and the mental capacity to pay attention to all of that. But we are trained through comprehensive training programs to pay attention to all of that, and this is why we know. And we always have continuous education approach. We have meetings where we share newer approaches that happen so that we all stay educated and optimize the service that we give you, because at the end of the day, we care for the doctor to feel heard and to feel that we are reliable, to feel like the surgery is going well, less anxious, doing safe surgery, and we care for the patient that's on the third side of the interface. Like, I don't even know them. The best I know is their name. Okay, we
Yeah.
care about that patient receiving good quality treatment. So,
And I want you to know it's what you're hearing right now, I'm not kidding, is exactly the conversations that are going on in every case that you do. So you're not thinking that. I assure you, most of us are not thinking about every single aspect, our mesodistal cantilever, vertical cantilevers, all the things we're about to talk about. And it's very, very good. Sometimes you want to know something? Sometimes your decision, and we might get to this, I do not know, is that I don't know if this is a good case to place an implant for various reasons. You may not want to go into vertical bone grafting that's required. You may have a compromised interarch space, things that we're going to talk about in a minute. It's an opportunity also to, and 3D diagnostics, once they do want you to have the best outcomes, and if they think it's not a case that you should be doing for all the reasons we're alluding to, it's a good time to know that, not the day of surgery.
definitely.
So let's talk for a minute about restorability and how's that considered in the
Well,
process.
there are a few things. So, I said that if you want proper evaluation of occlusion, you need to send us a bite. What happens when you send us a bite? When we plant the crown, we know if, like, what if the patient has a cross bite, an edge to edge bite? We know that the crown's going to be under a lot of forces. Can we accommodate that in the crown? We try it. We try to move the crown, the virtual crown, of course, on the software. We try to move it maybe a little towards the buccal, a little towards the mesial, distal. We try to accommodate the bite. If we can't, we tell you this implant will be under a lot of forces because we have bad occlusion. And the second thing we need to consider, which is very, very important, is the emergence profile, the emergence of the implant. Okay, see, there are a lot of cases where you can plant the implant in perfect bone, but it's really not restorable. So, how do we evaluate that? We have the number one, like, emergence that is very common, very preferred by a lot of doctors, which is screw retained restoration. To have an implant that is screw-retained, it means that your emergence needs to be in the center of the crown, around the central foci if we're talking posterior teeth, or at the cingulum if we're talking anterior teeth. Sometimes, in order to achieve that, you'd compromise the bone way too much. This happens more often in the anterior maxilla or mandible because of the bone anatomy, because of the bone inclination. So, in this way, we try to tilt the implant the closest thing to the incisal edge. We try not to go too facial, maybe a little in front of the incisal edge, a little behind it, but within that area. And at that point, you can restore it either with a cement retained crown or an angled screw channel if, of course, your implant brand provides that. Okay, and this way we know we are still close to the force axis, which we're going to talk about in a minute. Okay, to the force axis of the tooth, following the long axis of everything, mimicking the natural dentition that was there. Now, what happens if the implant ended up being way too facial? Imagine the implant being on the facial surface. This is the facial surface, and we're coming out there. Do you imagine the emergence of the abutment and then the amount of bulk that you're going to have to deal with around the buccal surface? Okay, increasing the bulk enough for the abutment and for the crown, it might end up being way too over contoured. Plus, it will cause a cantilever effect on the other side. So, back to the same issue, failure in aesthetics, possibly. It can cause gingival inflammation, it can cause pocketing, it can cause crestal bone loss to have such a bulky crown with such an anesthetic emergence. And it can end up causing the implant to be under a lot of forces because we are away of the long axis of the tooth. So our golden line is mesiodistally, try to follow the long axis of the tooth. How do we know that? How do I know that I'm easily inclined sufficiently? Like, how do I know? I check the arch. This is why we want a full arch CBCT. I check the natural inclination of everything. Okay, I check our crown, and we want to be within a reasonable amount of an inclination for it. How about buccolingually? We want to be as centered as possible within the crown and directed towards the functional cusp of the opposing arch. So the functional cusp of the upper is the palatal, of the lower it's the buccal, okay, and they hit each other in that manner. So we want to try to be within the force axis, almost straight on with that force axis. And why? To keep the bone under compression, not under destructive forces like tension or shear. When we deviate, we try to deviate within a normal amount. In a lot of cases, it gets like really tricky. It's very restrictive. So we use custom abutments, angled abutments, or even multi-unit abutments to correct this angulation. Why are we bothering? To correct the emergence, to have a decent emergence profile that is aesthetic, functional, and hygienic. So you know that at the end of the day, when you plan an implant with such precaution, it's going to be restorable. You know the type of restoration you're going to do, whether it's screw retained or cement retained. You'd know if you need an angled abutment, an MUA, an angled screw channel. You know everything that you need to know. If you're planning for a bridge, you know exactly if they're parallel, if there's deviation, if the deviation is too excessive, if it's minimal. So you can evaluate all of that. And all of that can be the root cause for your restorative success in the case.
Let's talk for a minute with something that I find you, particularly, I always tell you this, to be very, very knowledgeable about when it comes to the process of surgical and prosthetic implant dentistry, and that is the significance of the occlusion and forces related. You want to comment on that?
Of course. So how does the occlusion work? Like, let's say in an ideal case scenario, we have a functional cusp hitting a functional cusp, okay? And the teeth fit into each other very harmoniously like a puzzle. no eccentric forces, no parafunctional habits. The bone stays under compression, which is healthy. The teeth, they're not facing any areas of premature contact, any area of excessive forces, which keeps the crown healthy. Okay, and again, this is in an ideal world. Now, what happens when we have tilts, when we have malalignments, okay, or supraeruption, infraocclusion, any sort of that? So what happens is, if you have an area of supraeruption, this area would act like what we call a plunger cusp or area of premature contact. What happens when that happens? This area would be a stress concentrator that is consistently forcing excess amount of load over the crown. It wouldn't just cause excess load over the implant, causing the bone around the implant to deteriorate. It can also cause your crown to fracture. It can loosen up the screw. It can affect in a lot of destructive manner, as well as harm the opposing tooth that is in supraocclusion. This is why in many of our cases I tell you, this tooth is in supraocclusion. You might want to enameloplasty that a little bit, level up the occlusal table so that the teeth can like occlude in a harmonious manner. The second thing is when we have excessive tilts, when we have excessive like mesially inclined teeth or very rotated teeth, this can lead to quite the large embrasure if you don't do any adjustments. Okay, what happens when you have that large triangular embrasure? This is a food trap, which means it's a bacterial trap, which means it's like the root cause of a periodontal issue that's going to occur in like a matter of a year from now, unless the patient is obsessed with their oral hygiene. And even then, it still might occur. It might cause pocketing, it might cause the tissues to recess and the bone to recess along with them. Because the tissues, they reestablish the biological width no matter what. So if the tissues recess a little bit, the bone's going to follow that and is going to recess eventually. Okay? So this is why in a lot of cases, I tell you something like, we're going to need to flatten up that contact area by a bit of enameloplasty, or we might, if it's too excessive, we'll need to crown that tooth. We might
Yeah.
need to crown
So
it.
so again, in your planning stage, think about this for a minute. And here's what's going to happen. You're going to get good enough after you do 10 or 15 of these that you are going to automatically. I was not this way in the beginning. And it's not a good surprise. Let me tell you something. You don't want to charge a patient $5,000 to do an implant and a crown and then have them develop a food trap that you never spoke about. That is, they're going to feel it's your responsibility, and it is, to see these things coming. So one of two things is going to happen. Part of your treatment plan may be to crown the opposing tooth. So your treatment plan is number 30, implant, crown restoration. Number 3, crown, okay, to address the tooth that's extruded 5 millimeters. Let me tell you what else is going to happen. And as we speak tonight, I probably have at least, literally, 4 patients in orthodontics prior to me placing the implant. So that's, look, do you want to do things at an elite level, or do you want to do things at a mediocre level? And if that patient denies 5 months of ortho to straighten out the teeth that have tilted, then it's kind of a blessing to you that you didn't get involved in the case and have to, like I have before, and now you have to eat the ortho because you have you have the implant in place, and you never saw this because it was too early in your learning curve. Promise you, I've done it before. So I've paid for the ortho, or my orthodontist did it for free. Who cares? Because, you didn't see it coming. I don't want you to get freaked out that it's something complicates. You're going to get very used to, just like you do at a yellow light when you look left and right before you go through it. you're going to look and see how's my adjacent teeth. Naturally, if this is your implant and they're tilted like this, it's not a complicated thing once you start doing these to see this is a food trap, or I don't have enough space to create an effective restoration because my tooth above has come down. All things that are going to be matter of fact to you, I promise. Let's talk about now, doctor. Somebody's going to start their journey after they watch this. So what do they need to do? What do they need to do to start their journey?
So they need the appropriate tools. We've talked about the records, that's out of the way. They need the tool for it. So, what are the tools that we have? We have what we call a guided surgery kit. It's a kit just like the freehand kit, but with guided components. The difference is these guided components allow the friction between your drill, okay, and the keys or whatever you use, and the tube in the guide, what we call a sleeve, to guide you with the correct angulation, inclination, and depth control. And for that, we have two types of guided kits, whether it's a fully guided kit or a partially guided kit. The difference is a fully guided kit would provide you with guided drilling all the way from the initial osteotomy to implant placement. So you will drill fully guided, take your guided driver, and place the implant through the guide. The second option would be a partially guided kit. A partially guided kit would provide you with drilling sequence all the way until until you reach the end point, but then you'll have to remove the guide, take your guided driver, and place the implant freehand. For those partially guided kits, we have two subtypes, whether it's implant specific or it's universal. What's the difference, and when should I get one of them over, like when should I choose one over the other? The difference is an implant specific kit means it has the same geometry, it follows your implant brand. So let's say you use BioHorizons, so you'll get a BioHorizons kit. But what if I'm a doctor at my practice, I place all brands of implants? Okay, I place BioHorizons, Nobel, Straumann, Implant Direct, I do everything. What should I do then? Should I get a guided kit for each brand? No, you should get what we call a universal kit, like the one we have at 3DDX. It can be straight or can be tapered. It would provide you with a guided drilling sequence that is convenient for most of the guided implants. Okay, different diameters, different lengths to accommodate all of that. And then what you need after you're done with your drilling sequence is you remove the guide, you take the final shaping drill of your implant, you use it freehand, and then you take your freehand driver and place the implant. So let's say you're starting off and you place a lot of brands, go for a universal kit. You place a specific brand, but you don't want to place it through the guide, you don't want to be limited with a specific diameter, take a partially guided kit. You want to go all the way with maximum accuracy. You're not going to change this implant type, at least for now. Go for a fully guided kit and have the maximum accuracy. Now, this is for like the people that are going for a full drilling sequence. How about if you are an experienced surgeon who just wants to save time? You just want to mark your initial position, angulation, inclination, and depth. Okay, so you can, or what if you have a very limited restorative space? You don't really have the space enough for that sleeve that would accommodate your entire drilling sequence. In this case, what we offer is called a pilot guide. A pilot guide has a smaller tube. It allows you to drill your initial drill only, so it marks your initial osteotomy. If you're using a freehand pilot or like a random pilot that you have in your office, okay, it can provide you with angulation, inclination, but not all of the cases have depth control. Like for an example, your BioHorizons guided surgery kit, the one with the keys, not the Pro kit, Okay, it has a 17 millimeter pilot, a 21 millimeter pilot, 24 millimeter pilot. So we can set the depth that it provides you with depth control. But other brands, they don't have that available. So what you have to do is measure it and adjust it freehand, but at least you'll have 2 out of 3 points covered, angulation and inclination, which is very important because once you have the center, expanding is so much easier. But if you don't have the correct center point, this is when life starts getting a little challenging. Okay. There are other options, like we can provide you, this is something that I always tell the doctors, we can provide you with a long stop drill, which is our pilot. It has different lengths, it have a physical stopper, it's 195, so it's not that large, convenient for most of the implants. It would provide you with angulation, inclination, and depth control. So say you're someone who wants to start like slow, you want to take it at a normal pace, and you don't want to purchase anything from a specific rep yourself. You're not sure you're going to get the right item and you want to get a feel of it. We tell you, I'm going to give you a pilot guide. Okay, I'm going to give you that pilot drill. You can use it, mark your initial osteotomy and proceed freehand, or we can loan you our kit. You can get a feel of how guided surgery goes. Okay, and if you like it, if you feel like this is actually a good choice, it's a good opportunity, I want to go on doing that, you can go ahead and purchase a specific kit, or like an implant specific kit or a universal kit. You can proceed with whichever piece you want. So you don't have to go all in when you start. All we need is a CBCT intraoral scan, and we're going to assist you through every other step of the way up till the point of follow ups and feedback.
So nobody's interested, not 3D diagnostics, not me, in you over purchasing things for your initial journey. So when you get out there, like if you came through my institute, we do use BioHorizons. I've used them for 30 years. Naturally, that's what I'm used to. Um, so a lot of students that come through my institute, that's what they use. But you may go somewhere else to train, and maybe they use Straumann or any one of the other companies, Implant Direct. Um, I do you know offhand? Because I do not know. I think will companies give them a loaner like you'll give them a loaner? I think they do, don't they?
I think yes, I believe yes. Dental reps, they normally offer you like a loaner kit, okay, in case you want to
Yeah.
try this.
Not only will they loan, I'm almost positive this. This is, I always want to give you accurate information. That's why I hesitated. They'll also usually send a rep down chairside for you, your first case or your second case, and you want all the support that you can get. So do what doctors say. And in the beginning, don't go in and buy I don't know how much a kit is anymore. It's been a while, but $3,000 or whatever they cost. Don't do that until you're very comfortable with the system you want. And then once you do get used to a system, I want to tell you, I go fully guided, except in a couple instances. You're going to become very familiar with something called VersaBurs. VersaBurs. And so a lot of times I'll order just the pilot. And it's a big deal because the pilot guide, as Dr. Etchery's telling you, is giving you two facets. It's not giving you depth. So what do? It's giving you angulation, and it's giving you
Inclination.
what's the second thing?
Easy to say.
Angulation and inclination. So what do? I have a millimeter ruler. I've been doing this 30 years. I don't care. I measure every drill if it doesn't have a stop on it. So that's what you'll do. It's not a big deal. So I just wanted to point that out.
And by the way, additional information, there are a lot of provided stoppers that you can purchase, and it acts like a physical stopper. You can apply to your drill. Okay, so this is also an option if you have a pilot and you just feel like you're uncomfortable with the entire idea of depth control. You can get one of these stoppers, put it over your drill, and it would mark your depth. So, in all ways, what we care for is that you go through a seamless surgery. And if you have an obstacle in there, like buccal bone defect, radiolucency, radiopacity might be your remaining root. An area that looks a little peculiar, super soft bone, we're worried about primary stability. You'd know all of that. And regarding VersaBurst, they're lifesavers in a lot of situations, but in a lot of situations, we tell the doctors not to go for it. And this is something that is very important. I know a lot of doctors feel a little frustrated when they're having a case, and I tell them, you shouldn't do that, or it wouldn't be the best option. What I do, my personal approach towards it is that I plan it and then I show them all of the compromises of the plan. In a lot of cases, I'd offer you a restoration. Like I tell you, you can do an immediate on this one, immediate loading. You can take a healing cap, or don't do anything. Put a cover screw on top of that, let it heal, and uncover in like 4 months. Okay, in a lot of cases, we tell you you'll need to profile the bone for this. You won't need to profile the bone. If you're going to delay the load, don't profile the bone. Allow the bone to remodel first, because you might not need to remove anything. So, in a lot of cases, we don't always push for the do. Sometimes we push for the don't when we know it's not wise to proceed. Okay, and we've done a few cases together where we've planned things, we've seen all of the options, and then you decided, I'm going to two stage this. Actually, I'm not going to do this case. Okay, it's not a good case. And in a lot of cases, I tell the doctor this, consult with the patient first, because some doctors feel very, very pressured to make the decision and place the implant because the patient is adamant on having a fixed restoration in there. But on what expense? They don't really know that much. This is why you'd have an implant report so that you can show the patient the compromise. You can communicate that with the patient. So sometimes you feel like this is a very stressful decision. You feel a little uncomfortable approaching a certain case. Okay, we tell you if it's good or bad. Okay, we tell you if it's safe, if it has a lot of compromises, and we'd give you sufficient information to communicate with your patient. Okay, if the patient still insists, and let's face it, sometimes the patients insist on doing something, it's not really worthwhile. It's not worth it. Okay, but if the patient insists, at least it's on their account. They want to enjoy a couple of years with the tooth in there, okay, and they don't care about whatever happens next.
What about the different types of guides? You heard me say already my favorite guide. It's going to be your favorite guide too. A tooth supported guide is your favorite guide. It's like a puzzle. Slam, dunk, go home early, watch Netflix. It's a good day. Okay.
Sure.
What about the other types of guides, Doc?
Yeah, the other types of guides are tissue supported or bone supported. So we have three things we can follow. Teeth, as you mentioned, most accurate, fits like a Lego. So, and we have those verification windows, the openings you talked about. You can check if it's well seated or not. Okay, so it's very, very easy to deal with. The second most reliable and most accurate guide would be a bone supported guide. Why is that? Why is it winning over tissue? Because tissues are compressible at the end of the day. If you pin it a little too much, you might end up like a millimeter more suppressal than you intended. Okay, of course, we do our best and we give clear instructions on how to deal with a tissue supported guide, okay, so that that doesn't happen. But this is why a bone guide is more reliable. Bone guides can be a little tricky though, because you'll need to reflect. a full arch flap for it. And some doctors, they tell you, like, I tried it and it's not working, it's not seating, something might be wrong with the guide, but actually the problem was in the flap. You, out of all people, would know that when dealing with a bone guide, that reflecting a full arch, full thickness flap, this is very, very challenging. To make sure that the entire extension of the guide is seated over bone, this is the number one step that you need to do. Make sure that your reflection is a sufficient reflection. And even with the bone guide, we give you verification windows, the same openings in the guide, to verify that the guide is well seated, it's well supported, it's flushed with the bone. Okay, you don't have any rocking, you don't have any movement, so everything is great. Okay, and then you go in and you stabilize it into the arch with what we call a fixation pin. Okay, now the third type is a tissue supported guide. If it's that unreliable, why is it in a lot of cases a good option? Well, because not all the patients are the same. So with some patients, they have pre-existing implants. Like for an example, a patient had 4 implants in the lower, one failed, we need to add one instead. If you reflect a full arch flap, flapping means bone loss. Some doctors try to avoid that by regrafting crestally around the areas where the implant exists, but it's a lot of hassle. So at that point, I would try and push towards a tissue supported guide. Let's not reflect a flap, let's not expose the implants, let's try to do it in the most benign manner. The second type is, let's say, in a lot of the cases, especially with old age patients or dental old age when they've lost a lot of their teeth, you'd find the inferior alveolar nerve and the foramen, they're almost on the crest. And we don't really want to injure that. We don't want to cause any harm to the patient. So we'd push towards not opening up a flap and going for a tissue supported guide instead. Okay. A third case could be a patient factor. What if the patient is compromised medically? Okay, like we know that a full arch flap is a surgery, that's trauma that the body needs to deal with and heal. What if the patient's health cannot afford that type of stress? So let's go with the easiest option, which is a tissue supported guide. So it's not a bad guide, it's not an inaccurate guide. It will be accurate, will give you all types of accommodations to make it fit and to verify the positioning. Okay, and it is required in a lot of cases. But if I'm going to mark them from accuracy, it's going to be teeth, bone, then tissue.
Sure. And they do give you, when you do a soft tissue guide, there's parameters that they're going to tell you about to do what's called a pin positioner, right? Pin
Yes.
positioner guide.
Pin position.
Yeah.
Yes.
That allows you to know that are you in the right spot? Okay. When you put the soft tissue guide down, it mates and matches up with a pin positioner where you're going to put your fixation pins. I will say this to you. If this really is the beginning of your journey is going to start with tooth supported guide. Some of the tooth supported guides are going to have fixation pins because you have a distal extension, you don't have posterior teeth, and you need stability. So you also, it doesn't mean because it's a tooth supported guide that there will not be a fixation pin associated with some of them. And so that's a good introduction for you, by the way, to get used to. Like, I know what it's like. I didn't forget it. These drills are way bigger than drills you've used before. So when you're going in with a fixation pin drill, it's something very foreign to you, and it's good to get used to it before you go to a bone supported guide. And that'll probably be your next level of endeavor in implantology. And I'll tell you something. You can't underestimate what Dr. Etchery said. I can tell you firsthand, anecdotally, that the bone positioning, there's a moment. So you flapped, right? and now you're going to your sterile setup and you're picking up the bone supported guide. I've done many, many, many of them, but there is a little angst: is does that fit? The number one reason it will not fit is because you have not flapped enough. So when I have a bone supported guide, I am taking an extra 20 minutes and really making sure I am fully flapped. I am probably tying back my lingual flaps. Go Google what a tie back means. And sometimes I'm sewing the buckle flap to the cheek to get all the hands out of all the interferences out of the way. So when I'm pushing and getting ready to place that bone supported guide, I'm pretty certain, and I have my dental assistant who's very trained. We clear on that side, clear on that side. These are all things that are going to become matter of fact to you, and then it becomes very predictable. So, thank you, doctor. This is good stuff. What about it says? What do you offer on your end to your doctors?
Well, what we offer on our end, it starts from the treatment planning part. Some doctors, they don't really have the time to do the sessions, so they just want a treatment plan sent to them. They'd review it. If they feel like this is not exactly what I want to do, they'd get back to us back and forth with emails until we reach a final plan. Okay, and we call those offline cases. Okay, the second offer that we do, the second thing that we offer is an online session with trained professional dentists who know all of the information that I know. Like, I just want to say this: I'm not special. I've had seniors above me, team leaders, people that are maybe 100 times more knowledgeable than I am. Okay, and like yeah, but they've mentored me, so I gained all of this knowledge from them. So everyone in the office has the experience with treatment planning. So during any of your online sessions, we want to make sure the doctor is feeling greeted. Like, this is not something that I entered because it's my 9 to 5 job and I have to be here and I don't like it. No, we love it. We love helping you out. Okay, so this is number one thing. You're dealing with trained professional doctors who will do everything within their knowledge, okay, to optimize your plan. The third thing, of course, the surgical guide, whether you want us to print it and ship it to you, or if you have a printer and you just want the design and we send you the design and you print it, we can offer you a restoration that comes with the implant, okay, a healing cap, all those sort of stuff. The fourth thing when it comes to normal case that we, or actually every case, is that we send feedback emails. We want to know how the surgery went. Did it go well? Did you have any issues? And if you had any issues with the guide, we advise to schedule you a feedback session, whether it is with the feedback specialist regarding the guides or whether it's with the restoration specialist if it's an issue with the restoration. We also offer, like, this is a little advanced for beginners, but we also offer full arch restorations when it comes to planning, stackable magnetics guides, and PMMA. We send it over to you, whether it's a prefabricated PMMA or if you want the design you printed yourself. We are also incorporating the newest technology of photogrammetry. Okay, we are incorporating all of that, and we can even send you assistance because using guides can be a little tricky at the beginning, especially in full arch cases. Okay, maybe not for tooth supported. For tooth supported, it should be fine. But for full arch cases, it can be a little tricky, a little stressful. So we'd send you one of our assistants, okay, who've been trained to do this for a long, long time. They'd help you through every step from the moment of doing your flap up till the moment the patient walks out of your room with a full set of teeth that is made of PMMA material. Okay. And by the way, almost forgot to mention that, but After you do a session or after you confirm on any case, whether it's single, multiple implants, complex, all on X, whichever case, we send you what we call a confirmation email. What is that confirmation email? It's an email that includes all of the details that we discussed, the type of implant you're using, the guided kit, number of implants, anything to be extracted. We'd also send you a PDF or an implant report, okay, that shows you the implant from multiple cuts. And it includes the article number for your implant in case you need to order it. You don't have to worry about which implant was that, which type did I select, which size. You have that article number over there. And also, if you're printing, it will include the article number for the sleeve in case you need to order it. The second thing we send you after our quality control team reviews the case one more time, okay, would be an instruction sheet. The instruction sheet gives you the exact drilling sequence, okay, for the surgery so that you know how you're going to start and where you're going to stop. Okay, what are you going to use if the bone was a little softer or a little denser? And a lot of doctors at the beginning, especially like with their first case, they look at the instruction sheet and they're like, I'm not sure which one should I use. So they end up calling us and we explain that bit by bit. So if you tried it and an email like that was sent to you and something in there felt odd, like I don't know what that is, you can always contact us. And this is one of the most important things to me, at least, that I feel we provide, which is support, whether it's before the surgery, before the session, after the surgery, after the session. At any point, we're here to help you. Of course, there are times where we're having a little rush, but we're always keen on calling you back, emailing you, adding the note with like stars and additional points around it that we found one and two and three there. We can also offer you a radiology report if we find like a peculiar uh, object in the bone, like something that looks odd, or a nerve tracing session if we can barely trace the nerve, the bone is very soft, we don't really know where we are. We can offer you a biomodel that you can use for educational purposes. Like normally, a general practitioner would order it for educational purposes for the patient, and someone who's giving courses like yourself can get it to show the students, okay, but in a physical form instead of a virtual form. We can also, if you want to learn exactly what we do, we offer you to buy the software, we offer you training sessions that accommodate your needs. We give you a certain amount of sessions, and then you can request additional sessions as far as you can go so that you can plan your own cases at your own time if you'd like to. You can even plan them and send them to us, and we just fabricate the guide. Okay, so we try to be there in an all inclusive environment for all of the needs of the doctors.
Okay, well, listen, um, I said it earlier in this podcast. I hope you know me by now. I have no commercial interest in this. This is purely who I use. I certainly can use all the companies that are out there on the internet, and I'm sure many of them have excellent systems as well. But this is who I've used for many, many years, and I would highly advise you to, at the least, call them up, and you're going to be treated exactly. What you saw tonight is every time for me. This isn't like, oh, she's exceptionally pleasant tonight. It's always this way.